Okay, I am going to be sharing screen in a moment. And what we're going to do is this is going to be fairly interactive. I'm going to start this off and we're going to try to engage this. So there might be times if you have something to say, just unmute yourself and chime in on some of those cues. But the topic for this, and to give you a little background on the presentation, I'm a trainer for what's called the Addiction Technology Transfer Centers, and was asked to develop a learning community for clinical supervisors that they could come in periodically and have small topics for discussion. If you ever go to a clinical supervision workshop, a lot of people have licensure if you're a supervisor, where you have to get a certain amount of continuing education on that every year. And a lot of them are fairly common. It gets into the ethics, it gets into a lot of your standard fare, and this goes a little deeper dive into some subtopics. Now, this one is on outcomes, outputs, and clinical reports. So going to the next slide here. First thing, with any clinical supervisor, your responsibilities are twofold. You really have two jobs. One is administration, and one is going to be clinical. If you work at a large agency, you might find that your job bends heavily towards the administration. But it's really clinical supervision or clinical mentorship that we need to help people hone their skills. You know, I had been a mental health therapist for decades until I got more in administration or even a faculty role. And what I could tell you as a clinician, I did my best clinical work behind closed doors with nobody looking. Equally, I have done my worst clinical work behind closed doors with nobody looking. Uh, so, as a supervisor or a clinical supervisor, how do you really know how well your therapists are doing? How do you really know how engaging they are with the clients if there's no direct observation? So, we really have to ensure that anybody with clinical supervision responsibilities does lean into how to help people hone their skills, how to do observe techniques, what are some ways that we can measure fidelity to different evidence-based practices, whether it's motivational interviewing, and there's a MIDI scale, whether it's cognitive behavioral therapy, and there's the cognitive rating scale tool. We have to figure out a way to better observe. But with this, supervisor's responsibilities is we need to identify needs, both with clients and maybe with the agencies. What are the trends going on in the community? What are the best practices to address those trends? Do difficult cases come to the clinical supervisor? Uh, those kind of items. But there's also their role of hiring, firing, structuring work, promotions, quality oversight. It's not listed on here, but if you've ever been any kind of supervisor in a clinical setting, you would know the term drama control. Uh, and that's something that nobody prepared me for, the drama control. And I have had to navigate things such as I don't like so and so's music, so and so's perfume is too strong. How come she can wear that and I can't? Uh, and it took a lot more of my day than I ever thought it would. Now, with today's topic, it really balances the clinical piece and this administration piece. So the first things first are we have to figure out if we're going to be doing any kind of outcome reports, if we're going to be doing any kind of output reports or clinical reports, anything like that, is what is treatment success? Do we really understand what treatment success is even in our agency? We can have, what's the client's idea of treatment success? I know when I was in private practice and I did some marital counseling, which is the closest I have ever been to Vietnam is doing marital therapy. But I would ask people on their first day, what is successful therapy for you? What is a successful marriage for you? There's all kinds of marriages. There's all kinds of ways to look at it. What is your definition of success? How would you know you're doing well enough that maybe you don't need the therapy anymore? You don't need the assistance. Uh, and what are people's definitions? If somebody's coming into drug and alcohol treatment, what is their definition of treatment success? And it might not be the same as yours. It might be, I just want to stay out of jail. I just want to appease my probation officer. I just want to keep my job. I want to keep my clinical license. Those kind of things. It's also, what's the therapist's definition of success? And I have met some therapists that their definition of clinical success is to resolve every single issue you've ever had in your life and arrive at a level of self-actualization to the point where if you walk in a forest, deers and birds come up to you just because of your peaceful nature. And that might not be the client's idea of success. We also have a referral source success. Referral source success might be, did they go to 8 groups? Did they attend all the meetings? Did they test dirty? Did they test clean? Those kind of things. So one of the first things we have to do is, what is treatment success? Also, are we just looking at a point in time of abstinence? One of the national outcome measures by SAMHSA that they came up with a couple of years ago is called abstinence at discharge. That was their view of treatment success, abstinence at discharge. But is that really telling of somebody's progress in treatment? We'll want to look at, is success different based on the services they've done? Is treatment success looked at differently in aftercare than it is in detoxification? Is it treatment success different in residential treatment than it is in a medication-assisted treatment program? So we really need to get on the same page with everybody in our organizations providing clinical services, is what is success in our organization? Now, a little context with this. And for this next slide, and the context with the element or the elephant talk, I found this image basically for the former director of psychiatry at Neomed, Mark Bunetz, and he loved talking about the blind man and the elephant story to find context. But when we're looking at context with this, there's a think tank, and this is a few years old and it's still telling. There's a think tank in Washington that informs practice and informs SAMHSA, Substance Use Mental Health Services Administration, on how to best implement programs. And they were charged a number of years ago to determine what are the best predictors of treatment success in drug and alcohol treatment. And they looked at a number of things. They looked at evidence-based practices. They looked at therapeutic alliance. They looked at about everything that you can find, risk and protective factors, the 40 assets. But what they determined was the leading indicator of positive or preferred treatment outcomes was simply access to treatment and retention in services once people got there. So with access, this is just one. If we're looking at something now, there's a group at the University of Wisconsin called NIATEX, and it is research and program improvement for behavioral health organizations, and it's housed in their School of Engineering. of all places. And for something, they took this group of social engineers, healthcare engineers, and quite like process engineers, and they gave them how can we improve behavioral health organizations? And they started measuring something called first cry for help or first contact, and then first face to face or first professional clinical service, and measure that time between. Now, I know quicker access has been proven, and this is just one or two studies, that the sooner we get people in, the more likely they're going to show up. And if I call Nicole's agency and I say, I'm dope sick, I need help, I need help today, I cannot sustain that level of desire. I cannot sustain that level of motivation indefinitely. So if all of a sudden I'm reaching out and I'm crying for help today and I call that agency and they say they could get me in a week from next Friday, the chances of me being able to sustain that same level of motivation is remote. So this is even one day later, about 72% showed up. 3 days later, only 41% showed up. So we're looking, if we wait from a Friday to a Tuesday even, we're going to look at some no-show rates on these appointments. Now with retention, it's the degree somebody stays engaged in treatment. So access is strike while the iron's hot, and retention is keep them there once we get them. Now, on that retention, there's a NIDA study that indicates that 50% of people that start substance use treatment in the United States do not complete treatment. So we have a 50% attrition rate, dropout rate, whatever term you want to use, of people coming into treatment. Walkaways, administrative discharges, AMAs, we have all kinds of terms for it. But those studies of 50% dropout rates are based on level of care, those studies that did that. And they're not based on the continuum. So we need to look at our continuum of services. We don't necessarily want to keep somebody in IOP longer, indefinitely, in as much as we want to keep them in the pipeline longer. We want to keep them in the step down services longer. We want to keep them in the medication assisted treatments that underscore all of these levels of care longer. So that's just something that we have to look at. Now, this is an actual case of someone that I was familiar with in Summit County, maybe about 10 years ago. He was a younger man. Well, to me, 36 is a younger man. I suppose for some of the P3s, that's like a seriously old dude. But 36-year-old man who was doing 10 bags of heroin a day. So street heroin, a bag is about 1/10 of a gram. So we're talking a gram of heroin a day, which is a lot. He was unemployed, didn't have any current income, and he was living with his brother, who was a known drug trafficker that would measure things on the coffee table in the house. So that's where he was living. He wanted to get help. He wanted to quit. So where he went to treatment is the closest place to his house. He just walked around, the corner, and he lived up in Highland Square area, and he went to the closest treatment program to where he lives, and it was a minority serving agency, and he went in and saw him the same day. Perfect. And they realized, well, you need, they did a complete diagnostic assessment and said, we're an outpatient services only, and you really are going to need detoxification. So they referred him to another agency. So he went to that other agency and he was able to get in that day, which isn't typical, but it worked out for him. So he's been in the system for 2 days and he's already on 2 agencies. That agency also did a diagnostic assessment, which is some of the same questions that the first agency just asked him earlier in the day. So now he goes through successful withdrawal management. He's there for, I'm guessing, about 7 days, and they're coming to discharge him. Well, they can't discharge him to home because he lives in a drug environment. So they referred him to a third agency, which was residential housing. And there happened to be a bed open, which again is not typical. So he's been in the system for 8 days and he's already on his third agency. And when he got to the third agency, they gave him the same diagnostic assessment that they had at the other two agencies just a couple days prior. Now, he was at residential treatment for about 60 days, which is good. But then when you're in residential treatment, you can't work, you can't save income, you can't save up money to get an apartment, you can't fix your credit, so he had some drug refusal skills. He was doing real well there and he was getting discharged, but they couldn't discharge him to home because it's a drug house. So he ended up going to recovery housing and there was a slot open, which again is not typical. So they ended up going to a fourth agency. So now he's been in the system for about 9 weeks, and he's on his fourth different agency, fourth different primary therapist, fourth different electronic health record, fourth different, health record. And again, he has to do an assessment. And he also went to aftercare because where he went to for recovery housing, they required that he goes to aftercare at least 1 day a week, low-level outpatient services. So here's a guy, and he had encountered some success. And I haven't seen him for a couple of years, but I know that he stayed sober for a good while after that. He stayed in recovery housing for about a year and a half. And while he was at recovery housing, the first 30 days he couldn't work, but then they go into three-quarter status where he was allowed to work while he's in recovery housing, where he could save up money and he could start looking for jobs, and he found employment and he was able to get his own apartment when he was discharged from there. So this is an example of how a continuum works. But if we look at that NIDA study that says 50% of people drop out and it's based on level of care, that means that if someone's in 100 people are going into detox, 50% don't complete it. Then 50 go into primary treatment, we'll say residential, and 50% don't complete it. So now we're down to 25. So now 25 go into outpatient aftercare, and if only 50% complete it, now we're down at 12. So from 100 coming in the front door, we only have 12 coming out the back door, and in a way, we are hemorrhaging clients. Not due to skills, not due to evidence-based practice, but we're just hemorrhaging clients, oftentimes at these transfers to level of care. And they do not complete. Now, medication-assisted treatment, if it underscores that, oftentimes the physician's practice is the one that's trying to connect the dots between these agencies, which is no easy task, especially if you're a small practice. So when we get into attrition, in the past, what we did with substance use treatment is we do well to stabilize. Somebody comes in, they have a crisis, they are stabilized, they are discharged. They're discharged and go to meetings, find a sponsor, get some phone numbers, and they drop out. They don't have the skills. They all of a sudden they have urges and availability happen at the same time. So they relapse and then they go back to treatment. They're stabilized, they're let go, they go back, they're stabilized, they're let go. And we have a system now where a lot of people are in treatment multiple times. Alexandra Laudet, which does, she's the most prolific author of Persons in Recovery. She has longitudinal research on people that are in long-term recovery. And she has found with people in long-term recovery, and her definition is they have been drug and alcohol free for a period of 5 years, because it's the 5-year mark that the lifetime relapse rate falls below 15%. But of those people that had 5 years clean and sober, they had averaged 3.7 different doses of treatment along the way. And part of that is we have a catch and release model that doesn't keep people engaged. So this is, again, it's just, it's one study. but this is Detox is a standalone service. So what this has is essentially if a person went to a standalone detox and they are very motivated for help, but they're not linked immediately when they're done with that detox to another level of care, they report a 91% relapse rate, 59% in the first week. So when we have catch and release type of crisis services or stabilization services like detox, we need to start looking at them as pre-treatment more than we do treatment in and of itself, because it puts people in a position that they will better be able to engage in residential treatment or IOP once they're detoxed. But if anybody's worked at detox, whether it's at a medical director or a recovery coach, you'll find that when people's body gets right, there's a big walk away of folks saying, I got this. I just needed to get sober. I just needed to get clean. I just need to go through withdrawal. I got this. And then they come back a couple weeks later. So this brings me to a defining outcome as a clinical leader or a clinical director. If you were a director of, say, a standalone detoxification service, what is the better outcome for you to target? Would it be abstinence at discharge, which was the SAMHSA's national outcome measure? And if you think about it, if somebody's in detox, abstinence at discharge is kind of a given. You're not really doing a lot of work to have that happen. Or is your targeted outcome referral efficacy with where you're sending them afterwards? Did they show up at their next treatment? Did they show up at IOP? Did they show up at residential treatment? Did they show up at recovery housing? It might take a little bit more effort to get that outcome because you'll have to do some calls. There'll have to be a relationship with the other provider that lets you know that they showed up. But it is much more meaningful if we're thinking of what is treatment success. Now, I know in Lorain County, a number of years ago, they were referring to, and I'll give the name of the agency, Stella Maris. It's a standalone subacute detox program in Cleveland, Ohio. And at that point, Lorain County didn't have any detox. So they would refer people to Stella Maris, and only about 50% and less than that would come back and come into a bed. So there was we called it an efficacy of referral rate. And the efficacy of referral rate back then, and this was about 15 years ago, was about 40%. We would refer people to Stella Maris, about 40% would come back. The board decided to give an incentive to the agency for referral efficacy. And that referral efficacy went from 40% to 90%. And all it was we had volunteers give them a ride back to Lorain County to a residential treatment program or to an IOP. So thinking about it, it was a little bit of an added cost. It required a little bit of a logistics, but in terms of a preferred client outcome, we went from 40% referral efficacy to 90% just by offering people a ride. And ensuring they had an open bed or an open slot when they return to the county. Now, oftentimes when we get into clinical reports, we measure what's easiest to measure. And a lot of electronic health records were born as billing software. So we do well to measure anything we bill with our EHRs. But the problem with that is we measure outputs. And if you go to a lot of organizations' annual report meeting or letter to their boards of trustees or letters to the community, it's chock full of the number of clients served, number of units provided, how many days of treatment they served, how many unduplicated clients they had, how much billed services revenue they did. But nowhere in that report does it tell you how many got better. So on a clinical supervision end, we need to come up with outcomes that are meaningful. And some of those would be, uh, what is treatment success? I mean, how do we measure that? Do we look at referral efficacy? And that could be referral efficacy to aftercare, from detox to treatment, from IOP to recovery housing, from IOP to mental health clinicians, from the detox agency to a longitudinal prescriber out in the community. There's a number of ways that we could look at that. But referral efficacy is something that traditionally we haven't measured. And the data would suggest, with our high dropout rates and the importance of retention, it is one of the most solid outcomes we can target. It will take a little bit more effort, but it will give a little bit more meaning to the services we provide. Increase in stable housing, increase in employment, and with SAMHSA, there's increase in employment and increase in employability. So employability would be, if I'm in residential treatment and I go to GED classes, that GED will give me a platform to job opportunities that I wouldn't have ordinarily had. So is there an increase in employment or increase in employability? Symptoms reduction. It's the classic. It's what we want to see. Now, there's problems with how we get symptoms reduction. We could do with depression, just do a PHQ-9 pre-test, post-test. Unfortunately, pre-test, post-tests don't always work well in community mental health or community addictions because of the number of people that drop out. We typically don't know when someone's last appointment is. They just don't show up to it, and we don't see them again. So there is some tools like the Mental Health Statistical Information Program. I think I know the Summit County ADM Board provides this. It's what's called a reflective post-test, where it's given to everybody at a certain time, and they will just say, you will answer questions of, since I started coming to this agency, I find myself less depressed. Since I have been coming to this agency, there has been a reduction in my use from this to this, since I have been involved in this agency. And that way we could get a glimpse of our entire population and services, and not just the ones that we can match pre-test, post-test records to. Increase in social services. This is one of the national outcomes measures. So if people are going to 12-step meetings and they're having things signed and they're bringing them into the agency, wouldn't be that much for somebody to count them. That when they first started, they've gone to this many, 12-step meetings. They've been to this many self-help group meetings since they have been here. It is a good measurable outcome, because we know increased social services and increased social connection with healthier people is a good outcome. So, and whenever we design a clinical report, we want to make sure it's balanced between those outputs and outcomes. But when I used to audit agencies at one point in my life, many of them leaned really into the outputs, and we didn't have a lot of that clinical symptom reduction type of reports. So some potential metrics to consider is, what's a clear definition of treatment success and preferred client outcomes? Has the organization come up with that? If you call an organization, can they tell you what is the definition of treatment success there? Something that isn't numbers, where they attended group, or the good old, they completed their treatment plan. We could come up with things, but that's not a clear definition. A balance of both outcomes and outputs, units provided, unduplicated clients, number of people that drop out of services, symptoms reduced, and there's a number of tools, and I could even send people some tools for symptoms reduction. Satisfaction survey data, because sometimes this can tell you if there is a therapeutic alliance or not. And we know the therapeutic alliance is a really important factor in successful treatment. So I guess what I want to open this up to, and I would really just bring this into a discussion at this point, of how does your organization define clinical success? And is it quantifiable? Are there different goals for each level of care? So I circle back that would the treatment goal for detox be different than for IOP? Would the treatment goal for aftercare or continuing care be different than that for primary care? Are your clinical reports balanced between outcomes and outputs? And how much time do clinicians dedicate to tracking quality improvement data? And this is something that we have to really look at. The university, we did a study in 2018 and we looked at burnout, and it was primarily amongst behavioral health workers in Summit County. And we asked executive directors and what they thought the leading cause of turnover and staff burnout was. And their responses, and this was on a survey with drop down menus, but their responses, number one and two, were low pay and vicarious trauma. But when we asked the same question to the clinicians, the direct care workers, their burnout had nothing to do with the pay. It had nothing to do with vicarious trauma. Usually, pay and patients are, you know what you're getting into. The overwhelming number of clinicians said it's documentation and productivity mandates. That was what was burning them out. That was what was having them leave agencies. So whenever we come up with an outcome, we need to come up with something that is simple and measurable, or we need to look at what piece of documentation can we jettison because we really don't use it, and then insert one of these clinical outcome type of pieces. And then why are these reports important? So I guess that's really all I got for this. So I'm going to stop sharing now and see if anybody has any questions, or can you respond to some of those questions?